Good evening, professors. Good evening, consultants. Good evening, senior colleagues and colleagues. My name is Dr. Odigbo Michael, a senior registrar in the Department of Anesthesia, Ahmadu Bello University Teaching Hospital, Zaria. And I'll be discussing this evening overview of cardiovascular physiology. The cardiovascular system is a system primarily responsible for the pumping of blood and circulation of this blood to tissues and organs for adequate tissue perfusion. The functioning of this system is what we attempt to discuss in the next 30 minutes. I'll be discussing this topic with the following outline: introduction, through cardiac cycle, to cardiovascular responses in anesthesia, and conclusion and references. By way of introduction, the cardiovascular system consists of the heart and two vascular systems, the systemic and pulmonary circulation. The heart pumps blood through these systems. The pulmonary circulation is a low pressure circulation that is primarily responsible for the oxygenation of this blood or for gaseous exchange. Whereas the systemic circulation, a high pressure system, delivers this blood to individual organs that allows for tissue perfusion based on metabolic demands. Blood pressure and flow are largely controlled by the autonomic nervous system. Surgery and anesthetic drug also play a role in this. The heart comprises 4 chambers, divided into the left and right side, each with an atrium and a ventricle. The atria are for reservoir of venous blood, whereas the ventricles are the major pumping chambers that help to deliver this blood into the vascular systems. The left ventricle is of utmost importance because it delivers the blood into the systemic circulation, which, as we have said before, is a high pressure system. As such, the left ventricle is not surprised to be much thicker and more muscular, with more muscular wall than the right ventricle. The heart has four chamber valves and ensures blood flows in one direction. The valves are divided into the atrioventricular valves and the outlet valves. The vascular system consists of 2 separate circulations, as I've mentioned. Blood flows through the vascular beds from the arteries, arterioles, capillaries, veins, and venules. The capacity of blood in each of these vascular beds differ, with the veins and venules being the reservoir or capacitance vessels, and the arterioles containing 10% of blood being responsible for the systemic vascular resistance and are known as the resistant vessels. The components of blood are listed here. Electrophysiology. This is practically centered on the electrical impulses of the heart because it precedes the myocardial contraction. The electrical impulses are usually due to change in voltage across the cell membrane, which leads to action potential. Though it is said that the myocardial contraction of the heart, occurs spontaneously, but is usually preceding the electrical impulses. Impulses commence from the sinoatrial node, which is located at the junction between the superior vena cava and the right atrium. Impulses are initiated here, transmit wave of contraction through the atria to the atrial ventricular node, where there's said to be a nodal delay to allow the contracted atria pump blood into the ventricle. Impulses in the AV node are transmitted via the left and right branches of the bundle of His to the Purkinje fibers, which hence was sent to the ventricles, both of which contract simultaneously. We can't discuss the electrical impulses of the heart without talking about the ECG or the electrocardiogram. So I know that this topic, because it's large, the ECG itself will be discussed by another presenter in the coming series. So you can see from the diagram, the electrical impulses of the heart are measured by placement of electrodes in different parts of the body. You can see the electrodes connected to the limbs, known as the limb leads, and the ones 1 to 4 connected, 1 to 6 connected to the chest, known as chest leads. Also they can also be classified as bipolar leads or unipolar leads, depending on whether it is connected, the lead is between two active electrodes or and just connected as an electrode measuring from an imaginary 0 point. On the right, you can see what a normal ECG graph or tracing looks like, with an isoelectric line running horizontally, a P wave, QRS complex, ST segment, T wave, PR interval, and QT intervals. Each of these having significance when it comes to the electrical activity of the heart. The P wave measures the atrial depolarization, which of course usually precedes atrial contraction. The QRS measures the ventricular depolarization, after which there's a pause known as the ST segment before the repolarization of the ventricles. PR interval, QT, as indicated. Pacemaker action potential. We talked about electrical impulses being generated from the conducting tissues of the heart to the muscles. These conducting tissues generate impulses, which are divided into 3 phases: phase 4, phase 0, and phase 3. They are unique in that they have a resting membrane potential, which is very much unstable. And it's unstable because of increased conductance of sodium in this phase. So it doesn't allow the resting membrane potential to stay for some time before additional impulses. In essence, at every point, impulses are being discharged, and due to the influx of sodium ion into the cell at this point in phase 0. Sodium ion impulses, sodium ion conductance increases the electrical positivity of the cell from -60 to -35, at which point, which is known as the threshold potential, the calcium channel ion begins, calcium channels open to allow a slight depolarization, a slow depolarization, which is a bit slopey, known as the phase 0, significance of which you might likely touch. Influx of calcium increases the potential of this sinoatrial pacemaker cell to above 0, at which point calcium channel closes and potassium channel opens, allowing for efflux of potassium. We know that potassium ion is positively charged, so efflux of potassium out of the cell will cause the cell to become negative. Electronegativity increases to its lowest value of 60, at which point the cycle starts all over again. Note that the resting membrane potential never is never stable. It's always discharging. Hence, the name automaticity being experienced by the SA node. The SA node has the highest rate of depolarization of all the pacemaker cells. Therefore, it is the primary pacemaker. But in situations where it fails, the other pacemaker will be triggered to prevent electrical stasis, even though the rate of depolarization would be reduced. The cardiac myocyte action potential is a little bit different. Look at the diagram. We find out that it starts from phase 0 slope than what we saw in the pacemaker potential, because here flux of sodium ion, unlike in the pacemaker where we had slow influx of calcium ion. This rapid influx is responsible for the very steep zero. And because there's rapid, sodium channel suddenly closes, allowing for influx, opening of potassium ion, which is known as the initial or early repolarization phase. The early repolarization phase is closely followed by the phase 2, known as the play 2, characterized by the influx of calcium ion. This calcium ion influx is responsible for balancing of the initial repolarization caused by sodium efflux. This prevents the cell from tetany, and at this point, no extra or stimulus can cause stimulation of the cell at this point. After the placement phase is followed by a descent caused by closure of calcium ion and influx and continuous efflux of potassium ion, which never closed at any point from the initial repolarization phase. And because potassium is a positive charge, as it leaves the cell becomes more negative. Down until it gets to its lowest electronegative state of minus 80 millivolts at 85 millivolts, at which point the cell goes into its resting membrane potential. But unlike the pacemaker potential, this is a bit more stable. That is why it is found along the horizontal axis with the aid, and this stability is made possible by the potassium ATPase pump, which prevents continuous influx of sodium into the cell. It allows these ions to move against their concentration gradient. In essence, potassium, which is more inside the cell, are moved into the cell. Sodium, which is more in the extracellular, are moved out of into the extracellular space against their own concentration gradient. This helps maintain the resting membrane potential. We can't continue discussion without talking about key concepts of flows when it comes to cardiovascular physiology. Concepts like the stroke volume, the volume of blood pumped by each ventricle with each heartbeat. It is said to be about 70 to 80 mils, relatively constant, but can increase as it is usually being determined by the preload, afterload, and contractility. There's a relationship. The preload is the volume of blood at the end of diastole, and there's a relationship between the preload and the stroke volume. As the preload increases, the stroke volume is set to increase. Why? Because as the heart is constantly or increasingly getting filled, its muscles are stretched, which leads to increased force of contraction. And that's what the Sterling's law is all about. That Sterling's law states that the force of contraction of the myocardium is very proportional to the initial fiber length, which is determined by the amount of blood coming in essence, preload and stroke volume. Preload, afterload, contractility have factors affecting them, but of such as volume depletion, such as venous return, but what is constant, constant factor relating to all of them is the sympathetic nervous system or the autonomic system that affect virtually the three factors or the affecting stroke volume. Heart rate is number of contraction, number of heartbeats per minute, said to be increased by sympathetic nervous system hormones, and the exercise decreased by blood volume, decreased by parasympathetic nervous system and others. Cardiac output is the volume of blood pumped by each ventricle per minute. It's calculated by multiplying the stroke volume by the heart rate. Cardiac output must be said, it must be noted that the cardiac output changes depending on the metabolic demands of the body. Blood pressure of blood in the system, usually closely monitored as it helps to maintain tissue perfusion. Mean arterial blood pressure is equal to 1/3 pulse pressure plus diastolic pressure. You can also get it by multiplication of cardiac output and systemic vascular resistance. But it's very important to note that blood pressure does not really indicate tissue perfusion. Control of arterial blood pressure, even though we're still going to talk about the effects of CVS in response to baroreceptors and other factors, I found it, since in the spirit of discussing blood pressure, I just wanted to touch on this part. The control of arterial blood pressure is usually controlled by specialized pressure sensors located in the carotid sinus and aortic arc, as opposed to carotid body and aortic body, which contain chemoreceptors. These baroreceptors have connection with vasomotor center, and the rate of discharge to the vasomotor center is dependent on a particular pressure at a particular point. In essence, when the pressure is quite high, it increases the discharge of the baroreceptors to the vasomotor centers, which now inhibits the secretion, the sympathetic stimulation. As such, parasympathetic takes over as nature abhors vacuum. This effect in the heart will now include reduced blood pressure, reduced heart rates, reduced stroke volume, which will eventually bring the blood pressure, which is high, to normal. Conversely, if the in the situation of hypotension, the baroreceptor decreases discharge to the vasomotor center, which is said to increase sympathetic stimulation, and the opposite effect take preeminence. Baroreceptor responses provide immediate blood pressure control, so that in scenarios of prolonged hypotension, stimulation of other mechanisms such as the renin-angiotensin-aldosterone system will take effect, allowing for spot water retention, balance or correct blood pressure. Cardiac cycle. The cardiac cycle is the time taken for one complete systole and diastole. Duration is approximately 0.75 seconds. 1/3 is systole and 2/3 is diastole. Or in the case of very fast heart rate or tachycardia, this approaches, the ratio approaches 50-50 and compromises diastolic filling and coronary circulation. The cycle can be divided into 6 to 7 stages. You just take a look at this. It's talking about the differences of the cardiac cycle. I think I might look at this one because this, in addition to the cardiac cycle, looked at all other waves which these are things that happen concurrently during the function of the cardiovascular system. Lower down here, we can see the heart sound, we can see the ECG reading. Here we can see the jugular venous wave pulsation. Here we can see the pressure volume loop or pressure volume curve. These things work hand in hand. I feel there's need to discuss them as one to make it easier. In the cardiac cycle, talking about pumping of blood, distribution of this blood or circulation of this blood to the tissue to allow tissue perfusion, adequate tissue perfusion. We said that the contraction mechanism of the heart is usually preceded by electrical impulses. And this can be shown in the ECG. As you can see, the P wave coming before A wave. P wave is atrial depolarization, which eventually leads to build-up of pressure, the contraction of the atrium, and pumping of blood into the ventricle. But as this blood is pumping to the ventricle, you can see that this A wave goes down, the pressure reduces, such that the pressure in the ventricle becomes higher than pressure in the atrium, closing up, shutting up this atrioventricular valve here. And because it is on the left side of the heart, we're looking at what the mitral valve. Closure of this valve causes the ventricular depolarization, which eventually will lead to a mechanical process called ventricular contraction. But then this valve is closed, the aortic valve is closed, pressure is rising because of contraction. It doesn't immediately lead to ejection of blood. It builds up pressure. And because it's building up pressure and no volume increase as the valves are all closed, it is called isovolumic contraction phase. And that is the beginning part of systole. As this pressure rises to above 80 or 80 and above, it causes the opening of the aortic valve, the outflow valve, causing the left ventricle to eject blood out of the system. This blood that is being ejected out of the system with time will also reduce the pressure in the left ventricle. And as the pressure reduces, what we have is a situation where, in spite of reduction in pressure, there's still a momentum that still pushes blood out until a point where the pressure in the left ventricle becomes less than the pressure in the aorta, and this causes the aortic valve to shut close. Well, what we're describing now to this point is what happens in the ventricle. An interesting thing is also happening in the atrium. If we're going to take note, while the pressure in the ventricle is building up, it cannot overcome the aortic valve immediately. So it pushes back on the closed mitral valve And because the mitral valve is very competent, it only adds to increase the pressure in the atrium that had already emptied. And this increase in pressure is what leads to this C wave that is seen in the jugular venous portion. Back to this side. While the aortic valve closes, the mitral valve, which is still closed, was, okay, let me put it this way. I say why this is ejecting, the atrium is being dragged, increasing its length, thereby reducing the pressure in it as the volume length extends due to the contraction of the ventricle. The atrium length, myocardial length, increases its volume. And as the volume of the atrium, emptied atrium is increased, the pressure drops. That allows for venous return into the atrium. That's on the atrial part. So that we don't just concentrate on the ventricular part. Something interesting happening on the atrial part of the heart. Passive filling is also happening while this ventricular contraction is going on. As the ventricular contraction continues, or the pressure, or pumps out more blood, and there's reduction in the pressure in the ventricle, the aortic valve closes. The ventricle is forced to relax. Let's look at what is happening in the ECG. T waves corresponding to the T wave, at which point you have repolarization T wave, and this repolarization causes the heart. But this relaxation of the ventricle is, the pressure is coming down, hasn't come below the mitral valve. So the mitral valve is still closed, aortic valve is closed. So it is known as the isovolumic relaxation phase. That is because both valves are closed and pressure is dropping, the heart is relaxing, and the volume remaining in the left ventricle is constant, hence the name isovolumetric contraction phase. So as this relaxation continues and the pressure continues to drop, and the atria is steady, what happens is that at a point, the pressure in the atrium rises because of that passive filling phase. Above ventricular pressure, which is dropping, and this is for the V wave that is seen in the jugular venous position, and it opens up, this opens up the mitral valve. As the mitral valve opens, there is now filling of the ventricle, passive filling, and this continues and is responsible for, it is said to be responsible for 70 to 80% of ventricular filling phase. The remaining 20% is by the contracted atrial stimulation or atrial contraction, which happens later. But remember that in tachycardia, because of the shortening of the diastolic time, this atrial contraction is responsible for about 40% of ventricular filling. On the heart sound, heart sounds are usually due to closure. Normal heart sound are usually due to closure of valves. So you look at it here. The first heart sound is heard at the closure of the mitral, as mitral valve closes, because the valve of the left side closes slightly ahead of the right side. The valve, the mitral valve closes before the aortic valve. So first heart sound is heard here, and as the aortic valve closes later, the second heart sound is heard. This is just trying to take a look at the link. Flesh, this slides just add flesh to everything that we have just explained. We're working within 30 minutes. So I just look at it this way, and the slide probably will be made available so that if anybody wants to look at it, you compare with what we have discussed. Another concept we want to talk about is not really an entirely different concept, but pressure volume loop. The pressure volume analyzing the cardiac cycle. It shows the volume of blood move from the left ventricle and how much pressure is generated. It involves a graph of the ventricular volume on the x-axis versus the ventricular pressure on the y-axis. It is spread in the anti-clockwise direction. Let's take a look at this. If it is read in the anti-clockwise direction, it means we're going this way. Okay, we've already said it's a graph of pressure versus volume. It's being read this way. So what is the implication? We start from the point where all valves are closed. All valves are closed means we have nothing is moving in and nothing is moving out of that particular chamber. that is isovolumic. The volume remains the same. And because the pressure is rising, we're looking at a heart that is building up pressure, contracting. So this invariably becomes the isovolumetric contraction phase. This pressure builds up until the intracardiac pressure exceeds the systemic peripheral pressure. This opens up the aortic valve, causing the ventricular emptying. You can see this point is a ventricular emptying. Some people will see questions why people are asked what happens in the mid-cardiac phase. If you say ventricular ejection, you're still in order. This pumping leads to, after emptying, what we have here is all valves still closed, but the pressure is coming down. Of course, pressure reduces during relaxation phase. And because the volume inside is the same from the fact that all valves are closed, pressure dropping, this side is the isovolumetric relaxation phase. So some significant points until you get to the end systolic volume. Some things to note are the stroke volume we've talked about. In the pressure volume loop, the significance, the pressure volume, the stroke volume can be gotten as the width of the graph, and that is the end diastolic volume minus the end systolic volume. Remember, the end diastolic volume is the volume at the end of diastole, which we've talked about as the preload. Then the stroke work, that's another thing they can ask. Stroke work, the significance in the area of the graph is the stroke work. Remember in physics, that pressure multiplied by volume gives us work. So in essence, you just find the area of this graph, and that gives the stroke work. Remember that there are lots of pressure volume loops in the body, or even in the heart. The right-sided, right ventricular pressure volume loop is slightly different from this. We're focusing on this for obvious reasons. Factors that modify the loop include preload, contractility, and afterload. These concepts keep coming up at one point or another. Preload. What is this preload? Preload is that diastolic volume that we've talked about. What is the significance of increasing preload to the pressure volume loop? As you can see, this is the normal one. As preload is increasing, it is shifted to the right. Just in case you get to be asked, what is the significance? You shift the pressure volume loop to the right. Okay. The next slide, contractility, the intrinsic ability of the heart to do work with a given pre or after load. It is gotten as the graph or the gradient of a point in the in the end systolic pressure line. You can see it touching here. So the significance of increasing is that you make the gradient to be a bit more steep slope. Instead of slanted, it's steep. So it moves it to the left, as you can see. The direction is moving to this. This is more straight than this one that is slanted. So that's the significance of increasing the contractility. So drugs that increase contractility of the heart will affect the volume pressure loop this way. The afterload, ventricular wall tension required to eject blood. What is this? It is, how do you get it? Slope of a straight line joining the left ventricular end diastolic volume to a point in the end systolic point, which is somewhere here. Increasing afterload will move it just like the preload to the left, just in case you one gets to meet kind of thing, just to understand the significance and what each of these does the pressure volume loop and the drug that can affect each of them. Coronary circulation, okay, because of want of time, coronary circulation, okay, the supply to the heart about 200 to 250 mils. The left side of the heart is thicker, and as such, there's high chances, high pressure area, there's high chances of compression of the left coronary, and that is why it is said that the right coronary supplies the heart at all phases of cardiac cycle, but the left especially supplies the heart during diastole. It's very important to note that. Control of the cardiovascular system, 3 factors control the vascular system: the nervous control, the humoral control, and the local control. The nervous system, the most important is the sympathetic and parasympathetic nervous system. So we're not going to forget about the baroreceptor reflex we talked about at the other time, and even our anesthetic drugs. We might come to them later. Humoral control. Hormones also have effects to play in cardiovascular control of the body. One, adrenal medulla. releases epinephrine, norepinephrine into the circulation. We talk about the renin-angiotensin system, which is stimulated or whose activity is in the kidneys, but which are stimulated, whose constituents like the angiotensin are produced outside the kidneys, because you even see the aldosterone produced in the adrenal cortex. These are in response to different factors such as pain, trauma, hypovolemia, hypotension, hypoxia, and what have we. When this medulla releases epinephrine from into the circulation, what is expected to happen is there is affectation of both the conducting and the muscle cells that affect contraction or electrical and mechanical activity of the heart, just to restore whatever change is at the moment affecting the normal. For the renin-angiotensin system, cell is activated within the kidneys in response to, okay, let's say decreased extracellular volume. Decreased extracellular volume has this way of stimulating renin release from we have specialized baroreceptors, or in quote, baroreceptors present in the kidneys. They are the macula densa. They sense this decrease and stimulate the body to release renin, or stimulate the kidneys to release renin from the juxtaglomerular apparatus. The renin releases convert angiotensinogen, a liver polypeptide, to angiotensinogen to angiotensin 1, which is taken to the lungs, converted with the aid of the ACE, angiotensin converting enzyme, to angiotensin 2, which now has three main functions. A potent vasoconstrictor, stimulate the taste center, stimulating the hypothalamus, and of course, it can also stimulate the adrenal gland, the cortex, the glomerulosa, to release the mineralocorticoid, aldosterone, whose effect is more marked or seen in the distal convoluted tubule, that allows sodium reabsorption. Sodium reabsorption, the osmotic effect allows water to come with it, balancing whatever deficit that stimulated it caused it to be released in the first place. The arginine vasopressin, or ADH, is released by the posterior hypothalamus in response to changes in plasma solutes. Acts predominantly in collecting ducts, is a potent vasoconstrictor. It is released in response to pain, stress, hypoxia, even volume depletion. Local control, autoregulation. The heart has a very good autoregulatory mechanism, or the cardiovascular system has a very good autoregulatory mechanism alongside the kidney and even the brain. But the ability to adjust in response to local metabolic needs is what autoregulation is all about. Example is in the exercising muscles. While the muscles are being exercised, they use up a lot of oxygen. This stimulates local release of metabolites that allows for vasodilatation and increased flow of blood to those exercising muscles to take care of their needs. Sympathetic stimulation can also increase in the exercising muscle, but this local effect has been known to be the principal mechanism by which the exercising muscles adjust to meet up with their metabolic needs. Cardiovascular responses to anesthesia. All anesthetic agents have direct depressant effect on the myocardium. They reduce contractility. Many of them reduce sympathetic stimulation. We said many because if you look down here, we'll see ketamine increases sympathetic stimulation, but it still maintains its direct depressant effect, meaning that ketamine needs stored catecholamines for it to increase sympathetic stimulation. So that in patients or critically ill patient, or a patient with depressed or that have very low or no reserve of catecholamines, ketamine will be counterproductive because its direct depressant effect will be more marked in such patients. Then for most of our anesthetic drugs, I would say, because they cause they are hypotensive in nature, if we have a hypovolemic patient with this fall in BP going in for surgery, there is likely to be compromise of tissue perfusion, which we would not want, and it is said to be more marked during induction. Volatile agent, what more important is local anesthetic agent that depress conduction of cardiac impulses. This has found therapeutic use in conditions such as haphazard impulse, electrical impulses are discharged haphazardly. So cardiac conformation. A local anesthetic agent have found use probably reduce this haphazard discharge to normal. Because how about in and are paralyzed as well, have the CVS constantly undergoing changes, which we must know at every point and guard against, just to ensure that tissue perfusion is optimized. Controlled ventilation. We know that controlled ventilation causes positive pressure ventilation, which increases the intrathoracic pressure, preventing relatively reduced venous return. This reduced venous return ultimately leads to reduction in blood pressure, which we must always guard against at every point to ensure that tissue perfusion is maintained, even though, like we said previously, that blood pressure alone or blood pressure is not the main determinant of tissue perfusion. For the spontaneously breathing patient with probably not adequate tidal volume, it's very important to know that there's possibility of CO2 accumulating in the system. Even though the CO2 is a good drive to respiration, you also know that CO2 has effect on the cardiovascular system. The direct effect of the CO2 is a potent vasodilator. And it can also act indirectly to the sympathetic system to increase systemic vascular resistance, both of which, when added, will cause increase in BP. These are things that we should also know. And of course, even the regional blocks, they have effect on the sympathetic, CVS. Regional block causes sympathetic blockade, and this sympathetic blockade, the effect in the heart can no longer be overemphasized. We've talked about it. They will have the cardiac sympathetic cells, which can also be affected by these local agents. And this probably can lead to sympathetic blockade of the cardiac sympathetic system, leading to reduction in heart rate and bradycardia, which we must always guard against when it occurs with other drugs, or be careful the quantity we use at a particular time. In conclusion, the cardiovascular system is an important system in management of patients under anesthesia. Good understanding of the physiology of the system is key to ensure favorable outcome in this management of this patient. Regulate adequate tissue perfusion is a must at all times to ensure its proper functioning and that of the body as a whole. Therefore, the importance of this topic cannot be overemphasized. Thank you very much. These are my references.